get started as people continue to trickle in. Tonight, we're talking about infections. This is our eighth session of round two of AO North America Link. Thanks for joining us. Just a reminder what AO Link's all about: listening, integrating, networking, and knowledge as we provide you with that foundational orthopedic knowledge to navigate your early careers. We appreciate the support of Dr. Lee and Dr. Kapetkin, our AO North America leadership, and obviously Dr. Aker, our chair of AO North America Link. We'll see if he graces us with his presence this evening. He may be stuck in the OR, but he usually finds a way to join us. As usual, you have me and Phil with you tonight. Phil's going to answer your questions in the chat box. We have two really awesome guests, Mary Kate and Ashley. Little 90s nostalgia for well, they're all probably too young for that, but Mary Kate, tell us a little bit about where you're from, where you trained, and I think people are in that phase of the cycle where they're about to match. If they're matching, fingers crossed. uh any advice for match day or the time thereafter?
Sure. So Mary Kate Erdman, one of the orthopedic trauma surgeons at University of Chicago. Match day was probably one of my favorite days of my life. It was certainly a big buildup. Um, I think the big thing after match is really enjoy that time. That's going to be the last big stretch of time you have until you're ready to hit the ground running, no matter what you do or where you end up. So really just make the most out of that.
Nice. Yeah, definitely enjoy the day. Ashley, how about you?
Hey everyone, I'm Ashley Levack. I'm an orthopedic trauma surgeon at Loyola University in Chicago. Yeah, I would echo that. Match day is a big buildup, and afterwards you have very few responsibilities typically. So I would advocate for using that time to travel. You'll never get 2 consecutive weeks in a row for many, many years to come. So.
I know Dr. Akers, one of Dr. Akers' favorite piece of advice is to not take your foot off the gas, though, and keep reading and pick up a textbook, which is probably the most valuable, but not the most exciting. Well, just put that plug for him. He said he just had to put an X-Fix on an open APC3, so hopefully he'll be here soon. But he's taking care of patients, which is most important, obviously. This is where we've been. We've talked about a lot of stuff. We have a few more interesting sessions left, so don't forget to join us for those. They are a bit more complex than the first round, but they are interesting topics, and we're hoping to distill it down in ways that help you along your way nonetheless. Don't forget to check out AO Milestones. Ask your questions. Keep those questions coming. You guys are usually really good about asking questions, so keep it up. We'll try to answer them as best we can. Don't forget to claim your badges and watch on YouTube later. Quick recap of last month when we talked about the shoulder girdle with Dr. Sayas and Dr. Chang. The shoulder is an interesting structure that when we have fractures, the involvement of the fragments is often dictated by those muscular attachments. So you're really managing the rotator cuff at the same time as you're treating those fractures. And so don't forget to go back and review your shoulder anatomy, specifically as it relates to the rotator cuff and your near classification for those fractures, as well as those approaches and where the nervous structures are in relation to that deltopec and that deltoid split approach, as well as some of that brachial plexus stuff, which drives us all crazy. Don't forget that when you see those shoulder dislocations, that they can occur in either the anterior direction or the posterior direction, and how you're going to recognize those here. You can see on the CT scan showing an anterior dislocation. That's relative to the glenoid and versus a posterior dislocation that we showed prior. Clavicle fractures are another thing that you'll often see in the ER, and there are a lot of pros and cons to fixing those. And the discussion is incredibly nuanced. So don't hesitate to go back and look at some of that clavicle literature that we suggested before, because it's certainly one of those things that is a very conversation driven decision process in terms of whether you're going to fix that or treat it non operatively. Tonight, though, we're talking about infection, which is obviously a challenging topic. It may seem simple, right? Somebody will say, oh, it's just an IND. You just wash it out, like big whoop. But actually, I think infections can be very challenging, and some of the approach requires very careful thought about how you're considering treating these issues and managing wounds and antibiotics and all these other factors that may not be readily apparent. So the objectives today as we navigate infection are to recognize when we should be worried about infection, and then how are we diagnosing these infections that we are commonly consulted about on the orthopedic service. And then we want to consider all the patient factors that may make patients high risk for infections, whether that be related to getting any infection or related to post the surgeries that we perform for fractures and other orthopedic related issues. And then specifically as it relates to orthopedics, we're always worried about the implants that we're putting in. And so honestly, when you get into the hospital, you're going to be more, you'll potentially scrub with general surgery or urology even. And they're prepping and draping. You're like, whoa, 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 there's no way that's sterile. Come on, guys. Our definition of sterility is a little bit different than theirs because we're really worried about our implants. I think Dr. Rout says you invite them to your party when there's a bladder injury, right, guys? Um, so when we think about infection, Mary Kate, can you talk to us about how you think about infection and how you're looking at patients in that setting?
Yeah, absolutely. I mean, obviously everything starts with a history, but infection, one of the things that's notable about it is it typically shows up with some kind of physical exam findings. Um, Patients, they have a lot of pain. Especially when you have an abscess, that those are patients that are quite uncomfortable. Infection can mimic a lot of things, but really hallmark features, you're going to have warmth and redness and swelling and drainage, especially after surgery and surgical incisions, something that you want to have a red flag up for that. Uh, the kind of basic things you look at for everything is vitals. Vital signs can tip you towards infection, but if they're normal, it doesn't mean they don't have an infection. So that's you can't rule it out with normal vital signs. Similar thing for labs, and we'll go through some of the details in this in later slides and some case examples, but labs can range from anywhere from stone cold normal to completely really off the charts, depending on the type of infection and the severity of it. But something that you want to get those working right away from a logistical standpoint, because it can take some time for results to come back depending on your setting. Once you have a little bit more of a basic kind of understanding of what you're trying to target, you want to be ordering thoughtful imaging, where the imaging that you get shouldn't be kind of shooting in the dark, hoping that you're going to find something. If you should really have some kind of plan of what you're looking for and what you're trying to rule out with it, because it can take time, can delay treatment if it's not something that's indicated. And lastly, another thing that typically to really hammer in a diagnosis of infection is you got to prove it, and cultures are typically your way to do that, which that can be done in a variety of ways, again, depending on the type of infection you're talking about.
When
Anything
you're
else
when
that,
you're
yeah, go
oh
ahead.
yeah, sorry to interrupt you. Yeah, when you guys order imaging, I guess how are you deciding what to order and what are you looking for? In this case, we order a lot of CTs, but that last slide showed an MRI. How often are you ordering those tests?
Yeah, I think it depends on the situation. So certainly you might find some indication of an infection on x-rays if it's very obvious, but oftentimes you need more advanced imaging. And so CT for us is usually the quickest test that you can get. It's easy to get overnight when a patient comes in, and it does give you some information. You can see abscesses on the soft tissue window, and you can see when there's involvement of the bone, like a sequestrum, where there's dead bone inside the canal. But the problem with it is it's just not very sensitive. And so if you have a concern for an infection and your CT isn't really giving you the information that you need, then you kind of jump to MRI for a more sensitive test. The disadvantage, of course, is a lot of our patients have metal. And so when you get either a CT or an MRI, you have to deal with metal artifact, which can make it hard to interpret the images that you have. And then MRI tends to light up for various reasons. And one of those reasons is fracture healing. So you can have bone that may look bright on T2 imaging, but it may not actually be infection. It's sort of hard to interpret.
Yeah, I think Mary Kate made a good point about like all of this. You're kind of doing all at once, right? Like you're putting in the labs, you're thinking about the imaging because things take time. I mean, it's really hard for us to get MRIs done. And so often we're doing CTs more commonly as well. But yeah, those are excellent points. This is our first case here. And so this is a 28-year-old male who has 3 days of forearm swelling, pain, and redness. And so when this comes into the ER, what are you thinking about here, Mary Kate?
First thing I want to know is how sick is that patient, because that to me is infection until proven otherwise. And that if that's more of a simple kind of superficial skin infection, that's something that may not be that urgent and may not even need my involvement from a surgical perspective. But that, based on these labs, that does not seem to be the case. So essentially, everything is up and elevated, and one of the things to consider is a life-threatening type of infection. On the X-ray, you can see you kind of have to see a few of these to pick up on it, but there's some irregularities in the soft tissue envelope that skin and that deeper layer is a little bit thicker and chunkier, that which correlates with that image from clinical image that we saw on the last slide.
Yeah, I think, like you said, vitals are important too. We don't exactly have those for this one, but like you said, all the labs are elevated, so there's something going on there. And then, yeah, on the imaging there's some concerns about the soft tissue, and then we get a CT scan, like you said before, because it's much quicker, and we can see some air here. It's not a ton, but you're right. Air on any image should be something you're a little bit worried about because sometimes we say you can see air in abscesses with some types of bacteria, but the big scary thing that everybody always talks about is like a necrotizing soft tissue infection. And so those are the things that you have to be at least in your differential. But in this case, with somebody with elevated markers and air there, it's something we're definitely going to consider taking to the OR for some type of irrigation and debridement. And so some of the fundamentals of that, often people will say, "Oh, it's just a washout, and you just take it back, you just get it done real quick." But I think it's a little more nuanced than that. And so, Ashley, when you're taking these patients to the OR for debridements, what's sort of your approach and your thought process there?
Well, first, I want to critically evaluate the imaging that you have because you want to make sure that you're getting the extent of the infection that's present. You don't want to do an IND and can go in without a plan and then miss a significant portion or loculations or infection in the bone if you're not if you're just debriding the soft tissues. So you want to go in knowing exactly the extent of the surgery that you need to perform. And then I always advocate for debriding before irrigating. You have to get all of the dead tissue out of there and all of the pockets of fluid and loculations broken up before you can start to irrigate. Otherwise, your irrigation won't reach the areas that you need to wash out.
Yeah, anything you add there, Mary Kate? What do you do in antibiotics wise? You put any antibiotic beads in, or you put antibiotic powders? When do you think about drains and stuff like that?
Sure. So one general principle I would add is there's a phrase that goes around that drives me crazy, and that's the solution to pollution is dilution. The variation that I like is the solution to pollution is a knife. And to Ashley's point, you really can't leave anything behind because you're just going to be back in the OR 2 days later. As far as antibiotics, I think leaving anything durable in there, I'll start considering that when there's bone involvement. If it's just soft tissue, I have not really left anything in the wound. And drains, if they're, I pretty much default to drains in the setting of infection.
Yeah, I'm just change that slide because it's kind of a gross one to move along there. But yeah, those are excellent points about how you're approaching irrigation debridement procedures, right? Like you want to get rid of all that non-viable tissue because otherwise, that's just a landing zone for bacteria to flourish. Before we go into case two, I'd just like to say howdy to Dr. Aker. He's joining us now, and so we're lucky to have him. He was taking care of patients, so we're
Greetings.
welcome.
Only other thing I'll add in that last case was that
Yeah.
sometimes the pus makes a huge pocket, whether it's in the thigh or the calf, the shoulder, wherever you are. And sometimes when you drain all that pus, it leaves behind a pretty good dead space. So one of the basic fundamentals, whether it's resecting bone or dead tissue, but it's just dead space management. So I'll have a pretty short fuse to put in a wound vac and bring these patients back a second time. Just try to a little bit of containment, the suction helps squeeze everything down and maybe makes a smaller dead space. Plus, if the infection is that bad, sometimes it's nice to come back and have a second look and make sure that you got it all too.
Yeah, absolutely. That's an excellent point. Because we don't want to leave big voids through which things can just totally reaccumulate. Next case here. This is a 29-year-old male, 5 days of knee pain, but no trauma, is already on some antibiotics. We're consulted for a septic knee. And so you'll see that you get a lot of these consults when you're on call. Ashley, will you take us through this one and sort of how you may approach this when you're in the ER, or how you like your residents to see these patients?
Yeah, I think you really have to get a good history on these patients and a really good exam. So some pertinent things about this patient is that he's a mechanic. He works on his knees a lot, and he's otherwise healthy. And then on exam, he had no effusion. He did have some erythema. It's pretty clear from the picture that he has some redness, and it looks like somebody marked that out. Maybe the erythema has receded a little bit because of the antibiotics that he's been on. But his knee range of motion is completely painless. It's a little tight when he goes into full flexion, but he has a pretty good range of motion, an arc of 110 degrees, and he's walking around the ER without much difficulty. And so that exam for me is really telling that you can't jump to conclusions. You have to think about whether or not you're going to aspirate the knee and how you're going to proceed.
Yeah, like you said, he still has elevated markers, but the exam is really something that's critical in this case. And sometimes people will call you and they haven't even seen the patient in the ER. They got that handoff. They're like, yeah, they told me consult ortho. It's like, did you see the patient? Because he's walking around, his knee moves pretty well. You should know the risk for septic arthritis in that setting is probably pretty low. And there may be, proposed disadvantages. I don't know. We talk about aspirating through an area of cellulitis. And it's usually one of those things where I don't know there's evidence behind that, but certainly you don't want to do it. It just like one of those things that doesn't pass the whiff test as being something that's prudent to do. So this guy, what happened with this guy?
So this patient did not get a knee aspiration, and he got some antibiotics in the ER, transitioned to oral antibiotics for about 2 weeks, and comes back to the office completely resolved, ambulating back to baseline. Just was a cellulitis.
And then how do you contrast it to this patient here? So this is an 82-year-old patient, also with that atraumatic knee pain, already on antibiotics as well. And then you're consulted again. And in this case, what's different about this one?
Yeah, again, the exam here is really critical. So this patient, in contrast, had a palpable effusion. So there's fluid in the knee, and he had pain with knee range of motion from 0 to 40 degrees. It was pretty significant, and 40 degrees of motion is not much. So with that, with his elevated inflammatory markers, you have to be a little bit more concerned, and I think that exam warrants an aspiration.
Yeah, this is a photo of an aspiration, so to speak, in a way. But how do you guys have your residents perform aspirations in the ER? How about you, Mary Kate? What are some tips and tricks around knee aspirations?
Sure. So first of all, for just sort of etiquette, you tell the nurse that you're going to do it, because these can be painful. And if you just go ahead and start doing procedures without giving the people around you a heads up, then it's going to put the patient in pain for the majority of these incidents. And it's just something, give them a heads up, because you don't want to find yourself making excuses later on. But as far as technically how to do them, the superlateral portal is going to be the easiest one to get to, and patient have them lying flat with their knee fully extended. You can usually feel the effusion pretty easily. Prep that area, mark it in advance, and then prep it, and use an 18 gauge needle, and have at least 160 cc syringe that you can load and unload, because sometimes you can get quite a bit of fluid out of the knee.
Yeah, I think here's a little bit of an odd one. It's just showing that supralateral portal, but also an outflow portal for somebody that had the knee sort of washed out at bedside was pretty sick. But the other thing I'd say that I think that sometimes is challenging, depending on your system, is identifying using the right tubes for the lab. And so make sure that's where your tip about talking to nurses is super valuable because the nurses will help you out with those things, especially when you're early in your system. Like, hey, where do I find the right tubes to send this? And then how do you send it? There's all these steps in there that you don't always think about that, if you make friends, and allies, they'll help you out. Anything you'd add, Phil, maybe?
No, I think Mary Kate made a great point. 18 gauge needle, have a couple extra 60 cc syringes because sometimes it starts flowing and it's tough to send a nurse or to walk out of the room with a needle still in the knee. So I think anticipating that is important, but that'd be the major things.
And what do you guys look at in terms of those lab results? How are you interpreting that, Mary Kay?
Positive grams to me, that's septic arthritis in every bullet point there.
Yeah.
I think you have to take into account some factors about the patient. What's their risk of having it? What's their exam like? So you have to have a pretest probability in your head. You could get contaminants and everything else could be normal. You just have to be thoughtful when you analyze things, and you can't just have a knee-jerk reaction to it.
Yeah, this one had 63,000 cells, 97% segmented neutrophils, which are a marker of an infectious process. There were positive crystals though. So in this setting, let's just poll. Are you washing this knee out with an irrigation and debridement, Ashley?
You're going to get so many different answers on this across the board, but for these patients with positive crystals, maybe they have a history of gout, maybe they've had something similar to this in the past. If they're feeling a lot better after you initiated treatment based on crystals, then I think it's okay to watch it, but very closely follow those cultures.
Yeah, how about you, Phil?
Yeah, clinical scenario driven. I'd say the majority of the time I'm washing them out if they're okay to go with these with 97% segs. That in addition to the white count would push me that way. But sometimes if they're really borderline, it's the 30, 40,000 with 90%, we'll watch their cultures for a day or two. So I think that's always a nice fallback if you're kind of uncertain is that we'll trend cultures and usually the medicine team is on board with that unless they're like admitted for their knee that they're worried about infection, the CRP is 200, et cetera, et cetera. But usually it's like their knee started hurting with therapy and they were admitted for congestive heart failure and then they consult you for septic knee. So a little bit clinical scenario driven. And sometimes it's a discussion with the team too. Immunosuppressed patients, kidney transplant, some of these folks have really involved services that it is definitely a discussion more than you just saying no, 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 no.
Yeah, absolutely. I think it goes back to that considering the whole patient. And sometimes it's a conversation where you're like, hey, we're in a gray area. What is your preference? What do you want to do? Are you more worried and you want to be extra cautious? Then I think, yeah, going to surgery may be an answer there. But that goes back to talking to patients, seeing patients, and not just hanging your hat on objective info in a computer somewhere. Then when you think about that, a lot of the data there is around native knees, and sometimes the markers can be a little bit different in prosthetic knees, and so it's important to consider some of the different thresholds around that as well. And what we want to do is just put a plug in. We're not going to dive into this because this could be an hour or more long talk in it and of itself, but you really have to be aware of what the latest criteria are to diagnose infection in the presence of prosthetic joint replacements. And so being aware of what is called the MSIS criteria, we have an article here that we plug for you to go read after this to add to your stack of your reading list and reference that. we're going to switch gears a little bit. This is a 6-year-old male who did have an injury, has negative X-rays, has pain and swelling, and isn't walking. This is sometimes a challenging one. How do you tend to approach patients like this, Ashley?
Well, with these patients, the history becomes a little bit more challenging. So you really have to talk to the parents. Sometimes children just won't cooperate. Maybe they're refusing to bear weight for some other reason. Maybe they're shy. You really have to get a sense of what's happening at home. And again, your exam is really critical if they allow you to get near them. Effusions in the knee are very obvious, and in the hip, obviously not so obvious. So evaluating an effusion is great if you can, but then you have to think about are there things going on that you can't see on your exam as well? This patient was clearly had an effusion, very much guarding when he tried to move the leg, would not ambulate. And that's what he was doing at home, which is why his parents brought him in again, despite having been seen when this started 2 weeks ago. The timeline also really matters, I think, for these patients. If it started yesterday or today, you may be thinking other things than if they're having continued symptoms. And then there are other things to think about. Are they irritable? Are they febrile? Those are other clinical signs, especially in the young kids, that you may get from the parents that you aren't going to be able to elicit otherwise.
Yeah, apart from infection, are there other things in the differential that you're worried about in these patients, Mary Kate?
Yeah, so knee pain in a pediatric patient can really go a lot of different ways. There's obviously infection. We're kind of headed towards septic arthritis or osteomyelitis and some patterns such as that. There's also conditioned transient synovitis, which mimics septic arthritis in essentially almost every way. Usually CRP isn't quite as high. And then, when you want to look like a real rock star on medical school rotation or medical student rotations, knee pain in a pediatric patient, you have to look at the hips as well. Slipped capital femoral epiphysis, or SCFE, is something that can actually present just as isolated knee pain and difficulty bearing weight, and a lot of the same kind of stuff with an isolated knee issue.
Yeah, kids are weird and challenging. I'd say that much. In this case, you're right. This is a septic arthritis case, and what's the thought process behind an MRI in this case, as opposed to maybe a CAT scan, Ashley?
Tend not to do CAT scans in kids unless there's a real reason, if I'm looking at sort of an intra-articular fracture or something like that. But in the case of infection, you have a couple different modalities. You can get an ultrasound to look for an effusion, or you can jump to an MRI. And depending on the age, you may even need some form of sedation or anesthesia for it. So you need a good reason to do it. But in cases like this, where symptoms have been present for 2 weeks, there's actually, a non-trivial amount of percentage of kids that will have concurrent other issues like subperiosteal abscess or osteomyelitis, and you don't want to miss that and just go in and wash out the knee, because A, you're not going to be treating the infection fully, but B, then you're probably going to have to bring the patient back to the operating room, and giving kids anesthesia multiple times is really not ideal. So
Yeah,
MRI can be used to just look for other concurrent issues to make sure you're not missing something.
yeah, we definitely want to know what we're getting into, and like you said, often avoiding radiation in kids is a good strategy. So, but in general, I think a lot of hospitals have protocols on this, so we just want you to be cognizant of that fact, and then be aware of what your hospital's protocols are. And then in kids, we use some different criteria to understand what the likelihood of a septic joint is. One of those things is the Coker criteria, which is technically specific to hips. You can see them listed here. As you increase the number of Coker criteria present, obviously the sensitivity and specificity of a septic joint changes. And so you want to be aware of that and be able to answer questions about that on your rotation. So continue to read up on that as well. And then can somebody, how about Ashley, summarize how you think about infections for me in terms of what's something that like that one guy is going to just be medical, not require surgery versus something that's clearly surgical?
I think anytime you have an abscess, that is something that will need an intervention. It's not just going to resolve with antibiotics. And that intervention doesn't necessarily have to be a surgery. It could be an aspiration or something like that, but it needs to be drained in some way if there's a real abscess present. So that's one of the things where it kind of forces you into the categories towards the right. Anytime you have an implant in place, I think you really have to be critical about thinking about whether that implant has been colonized. And typically that will bump you over to those surgical categories as well. And then, the intra-articular pathologies, the septic joints, those kind of fall into the same realm of abscesses. They're not going to just get better with antibiotics. That won't penetrate the area that is involved, and there's risk with not doing anything. So that's where I start to think about procedures. And then sometimes there's sort of a gray area where you have infected bone that may be surgical. It may also require medical management or some combination of both. But there's some gray areas in between the superficial soft tissue cellulitis and the more deep abscess infections. It's sort of a
Anything
spectrum.
oh, sorry, go ahead. Yeah.
Go ahead.
Yeah, it's definitely a spectrum for sure. Anything you'd add there, Mary Kate?
I think a big concept in infections, and to contrast it to something like fractures, where the badness happens at time zero, and you're not going to break a fracture worse. Infection is a storm that's brewing, and the trend of how a patient responds to treatment can really determine the patients that are in that middle column if they tip to the left or to the right. So if you've got someone with a wound infection that maybe you don't want to operate on them for whatever reason, a post-op infection, and a patient with bad soft tissue and really bad medical problems, that if you can treat them with antibiotics and they mount a response and heal that wound on their own, then that tips you to the medical side. Or a patient with osteomyelitis that you're treating with IV antibiotics, they have no implants, nothing else going on, and they're not getting better. Maybe they need some surgical drainage that without doing that, the antibiotics won't penetrate.
Yeah, those are really great thoughts of because it's not easy. It's not easy. Like you said, sometimes it's hard to interpret where they are on that spectrum. But that idea of response to that initial treatment is certainly helpful. So just a quick summary, and then we'll check in with Phil for some questions. We really want to harp on that evaluation, that workup, and how you're approaching those patients, and really getting a thorough history, but also a really good exam to differentiate those pathologies. And don't forget vitals, which fall under that exam, and then making sure those labs are cooking right away. And anybody you're worried about infection, ideally, they would have ordered those labs before they've called you. But I'm going to go out on a limb and say they usually often have not. And then think about those imaging modalities that are going to help you the most in terms of interpreting what's going on there. And that helps you in that decision whether you're going to operate or not. That is really the question for us. And when we do operate, making sure we're getting really good cultures. And we'll touch on that a little bit more. And don't forget to consider the Coker criteria in pediatric patients and really the whole picture as you're looking at these patients, because it's not always easy. Phil, any questions coming up in the Q&A?
Yes, we got one. I've got one thing to add about the PEDS case, maybe the most important case of the night. I don't know what's coming, but all of y'all as residents will be asked to go see a pediatric patient 2 weeks out from injury. It's like this is kind of ridiculous, they want us to put a splint on. There's not even a fracture, whatnot. And I think I heard Dr. Aker say it at some point, but the concept of seek disease, that's an opportunity really for you as an orthopedic surgeon to potentially diagnose a child with a condition that the ER may have missed or their primary care may have missed. And so just order a CRP. Just keep that in the back of your mind. 2 weeks out, kids not acting right, instead of just throwing it away, seek disease, because the result of missing it is really such a drastic change in their management. So you miss a septic arthritis, they get sent home, they come back bacteremic, septic, things go downhill. They end up having a very abnormal life after that. And it can really, you can be the one to catch that. And every 5, 10 years or so, we have one that gets missed. And ends up being a really good learning experience to remember that we are to seek disease. So one of the questions that was asked is about aspirating through cellulitis in terms of risking seeding a joint. I'm curious, Dr. Aker, thoughts on that. Can you seed a joint if you try to aspirate through cellulitis, or are we just not getting the correct diagnosis if there's cellulitis and the consult is for septic knee? How do you have your residents manage that?
Yeah, I mean, typically, there's so much more that goes into it rather than just that simple question. Typically, if someone is ranging their knee and it's relatively pain-free and they can walk on it and they've got some redness around the knee, I wouldn't even tap it. I wouldn't tap it to risk putting a needle through the cellulitis. I mean, the concern is that if there's cellulitis, there's clearly bacteria in the environment, and you don't want to put a needle through the bacteria and introduce which was previously a sterile knee joint with a bit of that bacteria. So usually if there's some erythema, there's a little scab like Dr. Levac showed, like someone working on their knees, but they have concerns with an effusion. There's usually an area where you can put a needle if you have a high index of suspicion. We also get a lot of calls from heart failure patients, heart transplant patients. These folks are on aspirin, Plavix, all these blood thinners. No one's checked their INR, but it's 5.4, and they're like, rule out septic knee. And if you put a needle into somebody's joint with a high INR, you can give them a hemarthrosis that potentially becomes septic. So there's risks and benefits to every procedure that you perform on patients. So just because the ER says, hey, we want you to tap this knee, we still have brains. You still have to assess the situation and determine if you think it's appropriate.
Tim, could you comment on neck fash, or is the trauma service, are y'all taking care of that? And then any pearls on the diagnosis? I feel like a consult a night, rule out neck fash, a little gas on the CT, a little redness on the leg, just kind of gets in. So do y'all manage that? And then any pearls on those?
In general, the Emergency General Surgery Service, EGS, at our hospital manages. They're sort of the ones that take the transfers, manage it. They're in-house, so they can quickly rush patients upstairs to the OR. That being said, we do get consulted now and again for extremity neck fash or post-op patients that have orthopedic implants, etc. I mean, the pearls for that are early operative intervention. I mean, usually the patients appear pretty sick. It's spreading rapidly. Someone has outlined something a couple hours ago at the other ER. By the time they get to your ER, the erythema has crept halfway up their leg, well beyond what was outlined earlier. Their white count, a normal person's white count is 6. These white counts will be 30, 40, 70, spiking fevers. These patients are sick, obtunded, and surgery is really the only hope for saving the life. So I think that's really all the med students need to know at this point, unless you think I missed anything, Dr. Phil.
I just wanted you to say mark it out. That's so helpful. You showed that picture, Ashley, with the marking around the knee and then the clinical history of it improving on antibiotics. It's like such a helpful thing to do. And usually it's rare to diagnose it on the first time you see them, but that just like you said, that kind of sequential exam, it spreads beyond in an hour. Their vitals are worsening, those kind of things. It is it's kind of like compartment syndrome a little bit, where rarely you'll see it and you'll be like, this is it, it's time to go. But then other times it's more the trend, and you get a couple of exams over an hour or two and then make a decision. So you crushed it. Perfect.
Great. Let's actually dive into some fracture cases now. So, this is a 52-year-old male fell from a ladder 5 days ago, and outside emergency room gave him antibiotics and closed the wound. A little bit of a challenging scenario because the patient had some difficulty establishing care, and then came back to a different ER now. So, how do you approach this patient, Ashley?
Yeah, so this is an unfortunate situation where with an open fracture, we would typically recommend that you admit the patient, give them early antibiotics, and do an IND before fixation, usually within 24 hours. But he unfortunately was discharged from an outside hospital and given 1 dose of antibiotics before leaving. So he's in an elevated risk situation where I'm concerned about infection, his potential infection risk from the get-go.
And do you just talk to him about that, or does it change your management in a way?
It can change your management. I think you have to talk to the patient about that extensively. You know, that they need to know that there is that risk involved. Either way, I'm going to perform a really thorough debridement and irrigation for any open fracture. In this case, I believe that I did use local antibiotics at the time of definitive management, just because of that elevated risk. And unfortunately, this is a difficult case. It's a long procedure that increases the risk of infection even further. So he has a lot of reasons why he's at risk. You know, without getting into the surgical details too much, this is the x-ray. He came back 2 weeks post-op and he had extensive wound drainage from multiple areas along the incision and the traumatic wound, which was sort of extended in a Z-shaped fashion to allow the surgical approach was starting to open up. So it was pretty clear that there was a problem.
Yeah, that's a good point, especially as you highlight that there was a clear and obvious drainage that basically tracked to the implants and to the surgical site. And so, which these are sort of newer guidelines that we've developed within the orthopedic trauma community as we've worked to model some of our infection diagnosis after that of the prosthetic joint groups. And so, similar to that MSIS criteria, we really want to have you do some reading on the fracture related infection consensus criteria, and specifically related to the definition and how we identify those. What are some of the important takeaways from the FRI criteria, Ashley?
So the FRI criteria have this suggestive criteria, which are a lot of your clinical exam findings, some radiographic findings, wound drainage, 1 positive culture. All of those things are indicative that there may be an infection present, but none of them in isolation or in combination diagnose a fracture-related infection. They basically say you need to work this up further to evaluate if you have a true infection. And then once you do that, there are some confirmatory criteria. So in terms of those, any one criteria that's listed there on the right-hand side is pathognomonic. So you only need 1 for diagnosis. Many patients have more than 1. The top 3 are ones that you can find in the operating room that pretty simply. And then the bottom 2 are based on pathology, staining, to kind of add to the criteria. But a lot of these are fairly obvious once you get in the operating room. If there's a sinus, if there's communication with the implant, pus, or you need to have 2 positive deep cultures from the same area.
So this guy essentially had confirmatory criteria based on your exam alone, right?
Yeah, it wasn't clear that it was wound breakdown communicating with the implant. However, with an olecranon on plate, there's not a lot of soft tissue overlying that area. So it was pretty concerning.
And so what's your strategy when you take this patient to the OR then?
Well, you want to get good cultures. You know, it's most likely infected and you need to be able to treat that effectively. So you need to obtain cultures. And this is sort of the strategy that I use when doing that. Some people get those swabs. They look like Q-tips that you dip into the wound. And those are really not effective. You really want to get tissue cultures. And you don't want to touch the skin. There's all sorts of other flora on the skin that could just be a red herring for you when you're deciding on your antibiotics. So I tend to take a minimum of 3. Usually I take 5 samples from different areas. If there's hardware that I'm explanting, I try to send the hardware. And a lot of labs can actually put the hardware in a broth solution and then sonicate it, like kind of shake it up to get the bacteria off and then culture that, that broth, which is very helpful, especially if you don't have a lot of true soft tissue or bone available for cultures.
Yeah, I think that idea of having an odd number is sometimes helpful. You want that tiebreaker in a way some of the time. Anything you'd add, Mary Kate?
I think this is an area that's prone to sabotage. Things you want to look out for. In a nice effort for the OR staff trying to keep efficiency up, they may open culture tubes early and leave them sitting on the back table for a couple of hours. And that's probably not something you want to do. You don't really want to culture the air in the OR. You want to culture the tissue. The other thing you want to look out for is making sure the cultures get sent and the specimens get sent. Uh, you're in a long case and there's samples passed back and forth. There's staffing that changes in the operating room, and there's some logistical things that have to get done. And confirming that your specimens were sent to the lab is something that is absolutely critical.
Yeah, I think I definitely had samples not get sent. So it is, then things become challenging for sure. In this case, in terms of your surgical tactic, what was the approach there?
Yeah, so essentially reopen the wound, get out any dead tissue. So do a really thorough debridement, and then thorough irrigation. And then you have to decide what you're going to do with the implants. In a situation like this, 2 weeks out, this fracture is obviously not going to be healed, and it's a difficult enough fracture to fix the first time around, that it's not a small thing to take out hardware. So in this situation, in an early post-op infection, I try to maintain the hardware as long as it's still doing its job. So washing it out thoroughly, maintaining the hardware here, and then those circular things on the x-ray are antibiotic beads made of bone cement or polymethyl methacrylate beads that are impregnated with antibiotics. In this case, we didn't have an organism yet, so you kind of empirically choose antibiotics with a plan to go back in and remove them at a second debridement.
Yeah, I think that's a common strategy for uh, addressing all the factors that we're worried about, that dead space, treating with antibiotics, getting out all the contaminated tissue as much as possible. And this guy actually did really well. Elbows get stiff, but this guy's got a pretty good range of motion after all that goes on for him. So that's a really interesting one. Mary Kate, how about this one? This one's a bit different. This is somebody who got shot. They had a fracture in the femur and they got fixed. And they didn't have any debridement formally, which we would say, ballistic wounds. It's a little bit of a gray area, but largely consider those closed injuries, textbook wise. But perhaps some evolving thought process there. And then that person gets lost to follow up after 3 weeks. Not uncommon for these patients who sustain ballistic wounds. And then they return, I guess, 7 years later. And now something
Yes.
else is going on.
Yeah, 7 years later, this is a perfect case for that junior trauma colleague to inherit. This gentleman showed up, no systemic signs. I think his labs were elevated a little bit. We'll get into that. You can see some broken implants and some screws loosening. You see some haloing around that nail, but you do see some evidence of healing. You usually can't walk on a non-union for 7 years without having issues. So he also has this wound that's been draining for a long time. So we do our vitals and our labs work up, and he doesn't have any alteration in his vital signs, but his labs are definitely elevated, and he's got a draining sinus. And if you look at the fracture-related infection criteria, he's got confirmatory evidence and obviously some suggested evidence as well. So for this, as far as surgical planning, you want to confirm that fracture's healed. You want to look for pus pockets and things like that. So he got a CT scan. And a big thing that we're going to try to do is get that implant out, because unlike the rest of the tissue in the body, the implants don't have an immune system. So you can give all the antibiotics you want, and the antibiotics are not going to get to the metal or the plastic or whatever's in there. The other thing that can happen is the bacteria that start colonizing on that, they create a substance that basically is this barrier around everything that blocks any antibiotics from having any efficacy. So you see that stat there, foreign material can increase the risk of infection by 10 to the 6th, which is quite high. But on the opposite side of that, fracture stability is also something that can ward off infection in a sense. There's a variety of studies looking at mostly animal models and talking about relative stability versus absolute stability and how rigid a construct is, or if a fracture is fixed at all. And a trend towards the more fixation and the more stability, the lower risk of infection, at least in a basic science kind of setting. So just something kind of food for thought, and something that I certainly debate with myself about. So heading into this case, what are your thoughts on, I know Ashley mentioned it, but thoughts on when to take out implants? This one's a little bit of an obvious one. Or when do you need to replace implants is sort of another variation of that question, I guess.
I think, yeah, I like how Ashley phrased it in the distal humerus, right? That's a hard case. And as you take things apart there, you may not be able to get them back together. So in my mind, that's certainly a consideration that weighs heavily when I'm considering that process. In this other case, obviously it's all healed, so it's all coming out no matter what. But yeah, that level of difficulty, I think, and is it going to compromise the outcome overall? And then, like you said, I think a lot of the variables are covered here in terms of the soft tissues being another issue. Are you going to have to reopen a lot more of the incision to go in and get some other component out, and then increase the wound area and potentially cause other issues? So it's certainly a nuanced question. There are a lot of variables to consider, but I think probably the most common is how healed is the fracture, and how much am I going to compromise getting stability if I'm going to look to exchange or change anything. Would you add anything to that list, Dr. Aker?
No, I mean, just to hit the easy button, an easy question is the hardware still doing anything? You know, like is it all loose? We've all seen those x-rays of like the plates with the screws that are sort of floating around like they've backed out or broken, or it's not doing anything anymore. Well, certainly then it's just acting as a nidus for the infection. So um, that's a quick question you can always ask. Is the metal actually still serving any purpose?
Yeah, that's great. Simplify it for sure. In this case, you took it all out and you did a debridement, and here it was a nail. And so we used a device that allows you to debride the canal, which is certainly a valuable tool. And then obviously debriding that sinus tract and getting rid of that tract. And then similar stuff with the targeted antibiotics, first starting with broad spectrum. Once you have culture results, then going to more targeted antibiotics. And then obviously keeping in mind that sometimes things require more than one debridement, like you said, especially with some of those cases where you're working to manage dead space. This is a different case here. This is a 76-year-old male with 2 months of knee pain, no trauma, but the bone looks a little bit weird here. So what's going on in this case, Ashley?
Yeah, this was an unusual presentation. He really, on history, had no reason to think that there was any cause of an infection. He didn't have any trauma. So it was sort of a weird presentation, but he did have some swelling, and his inflammatory markers were quite high. And then if you look at the x-ray, you can see some features that are concerning. So there's a lytic area sort of right above the patella in the center. And then you can see some periosteal reaction along both the medial and lateral sides of the metaphysis. So unclear why this happened, but there's features that are concerning enough for infection. And because of that, we got further imaging. In this case, an MRI was going to be the most useful. And here, if you're looking from left to right, you're looking down by the knee on the left and up towards the thigh on the right. And you can see in the back, so the bottom part of the screen, there's an abscess that's sort of escaped from the middle of the canal. And the infection is running up and down the middle of the canal as well. So it's a pretty extensive involvement of his osteomyelitis without a real cause.
Yeah, just a couple of other views here. And so what's the strategy in this case? Because it's a little bit of a different one. There's no implants there, but you still have an abscess that you got to deal with.
Yeah, exactly. So when there's no abscess present and you have some osteomyelitis like we touched on earlier, sometimes you can treat that with just antibiotics. But because of the abscess and because of the extensive intramedullary involvement, you really need to allow that infection to escape, and you need to do that surgically. So you need to resect any non-viable bone, and you need to allow that infection to come out. So to do that, you kind of create a channel in the bone, and curette and scoop out and burr out any infection inside the bone. You could also do it with an intramedullary ream or irrigator aspirator, but this one was so far distal towards the knee in the metaphyseal area, I felt it was best to go directly right at it. And then there is some dead space management that you have to think about, especially with the abscess that was in the back. So drains are a consideration, and I chose to use a dissolvable material that has antibiotics in it. It's calcium sulfate with antibiotics that will dissolve and leach out those antibiotics over time. And I placed them right in the canal so that they can impact the bone.
Yeah, you can see those here in that bone, within the canal of the bone. All those little sort of speckled items within the canal there, and you can see your drain that you used as well.
Yeah, the drain
Important
is
to
for the back of the knee where the abscess was sort of leaching out from the bone. And then of course you also need the prolonged antibiotics. The local antibiotics inside the canal aren't sufficient in and of themselves.
And then 3 months later, you can still see some beads resorbing over time there, eluting those antibiotics, hopefully, and helping to continue to treat that infection. In this case, did the patient have any of these factors that we begin to worry about?
Interestingly enough, he had no risk factors whatsoever.
Just one not on the list. Bad luck, I guess. But in general, we're definitely considering the patient or host factors in the presence of infection, because there are many things that can occur that increase patients' risk for infection. Some that we can control, some that we really can't control. Diabetes is a big one in the U.S., obviously, a big one for me on the border. Smoking is one that is modifiable. Substance abuse, other things, malnutrition. These are really important factors that we can work to optimize if possible. And then obviously we have to think about ourselves, because we're not free of blame. Like you said, in some of those hard cases, operative time. And then when we're going back in, debridements, making sure our constructs are thoughtful. And then obviously those injury factors. Sometimes that injury is just something that is so hard to overcome that we may not be able to tip those scales, unfortunately. Any other thoughts on the risk factors or patient factors side of it, Mary Kate?
Just that they often happen in batches where a patient with host factors on the left has an injury that requires extensive operative time, a big open injury, and usually it's a double, triple, quadruple whammy.
Yeah,
You
that's
just got to
a
do
good point.
everything you can to protect them.
Yeah, that's excellent. And we have things, as we've used more powder antibiotics and other things, but it's definitely always a challenge.
Did he
We'll
grow an
skip this
atypical
one.
bug?
Oh,
Can I ask a question? Actually, that's a really interesting case. Did he grow an atypical bug?
No, it was MSSA.
Very, very odd. The other thing I thought about looking at the imaging, sometimes in that age group with bony changes, biopsy what you culture, culture what you biopsy. So I'll have our tumor surgeons look at some of these. That's a really odd presentation that you described to, and you're kind of like having to get back into your differential diagnosis state of mind. So sometimes
Yeah.
multiple
That's so important that you mentioned that. This patient got an MSK guided IR biopsy to rule out an oncologic process before we took him to the operating room for that exact reason. It was a very weird presentation.
yeah,
Very.
that's an excellent point. Yeah. Um, we'll skip this one just in the interest of time. Quick summary. Don't forget to review that MSIS criteria, the FRI criteria. That's definitely a bit of reading that is best done outside this format, probably. Consider the whole patient, and then we really want to remind you to consider the balance between and the role stability plays in the process, because these are overall challenging cases, require nuanced approaches, as you can see from the examples. Any questions, Phil, before we sort of work towards wrapping things up?
Yeah, a couple I think that are good. I'll ask Dr. Aker maybe on this first one. Philip, great name, asked for a washout of an open fracture. How do you decide 3, 6, 9 liters, 12 liters? Do you do less or more if it's a small open minor fracture for that case that the distal humerus, it's been a few days, does that get 9? How do you decide?
Yeah, I've rarely been disappointed by using more irrigation, but like Dr. Erdman said earlier, the solution to pollution is a knife. We can say that till we're blue in the face. Open fractures with road debris, organic debris, dirt, stones, leaves. The best treatment is to just cut it all out. Sharp excisional debridement. I think in general, a lot of the medical students who rotate on the general surgery services, they hear that adage about the solution is dilution, but that's for the belly. When you have a perfed bowel and there's fecal contamination, I think tons of irrigation is a good thing. For us, I like sharp excisional debridement, and yes, plenty of saline. For us, usually it's in the ballpark of 3 to 6 liters, rarely more. However, there will be some grossly contaminated wounds that, for sure, it's debride and irrigate, and keep going back. And I don't know that there's a perfect textbook answer, but I will say more is more.
Awesome. The other question was about antibiotic coated nails or cement nails and which antibiotics to choose. I think we won't go too much into depth, but sometimes the culture results beforehand and you can then direct what you put in your nail in terms of what powders. But for me, it's usually a Tobra cement with some Vanco powder mixed in kind of a 2-to-1 ratio. It's a little bit of a chemistry set on the back table, and I end up wasting usually somewhere in the range of 10 to 12 grams of vancomycin for one nail. So that's just me, though. That's it.
Excellent. Perfect. Well, thanks so much for tuning in, everybody. I know these are challenging cases. Next month, we're going to talk about the knee and why an image like this should really start to set off some alarm bells, and not something to probably jump up that consult list as high priority. We'll talk a little bit about that next month. 1AO is also next month. So if you're able to join us out in beautiful Henderson, Nevada, feel free to tag along and do some learning out there in person. Otherwise, don't forget to get your badges. Check things out on YouTube for those recordings if we were moving fast through things for a little rehash. Otherwise, we'll see you next month. Thanks so much to Ashley and Mary Kate for joining us. And everybody have a good night.